to the work that we're doing. Basically, what attachment theory talks about is that patterns of security and insecurity are laid down very early in life, something we all know, and that they underlie all our later relationships when we're looking for help, when we've got a crisis, when we've got an illness, when we're relating to a caregiver. And of course the primary caregivers in our society are doctors as well as nurses. This is primarily an audience of doctors, so almost everything I'm going to say does also relate to nurses, but for shorthand I'll just say doctors. So we are the main caregivers. This sort of pattern underlies most of the things that we do, but really it's not centrally a matter that we attend to, not on the sort of curriculum, so to speak. And of course it's very puzzling for us because patients, when they come to see us, often bring all their past experiences, many of which they've felt sort of unhappy about, to us. And not only do they bring their past experiences of care to us, they bring their early childhood sort of preconditioning, which might be, and very often is actually for the people that consult us, quite complicated, quite insecure, sometimes abusive, so that they bring underneath everything else often an expectation that they will be let down. And that doesn't go very well with us, does it? Because we're sitting there thinking that basically we're the fountains of help for other people. So there's a very difficult interaction that is set up by these patterns that I'll refer to in more detail. Now, so it seems to me that basically we're a bit unbalanced in medicine. We're very good at some aspects, but we amazingly neglect others. So I think we're a bit like the Leaning Tower. I mean, we're still standing, but there's a definite list that maybe we need to pay attention to. And the thing that sort of makes us list, I think, is a lack of attention to the very interesting and important aspect of human relationships. But let me, before I come back to attachment theory, let me put my own professional life a little bit more in context with you. I practiced there in a National Health Service health centre in the middle of London. I started in 1972, completely confused by what on earth I was doing, and then realised, I suppose, rather fortunately, that provided I stayed quiet long enough in consultations, patients would usually tell me what was wrong with them. As somebody else later said to me, and provided I stayed quiet a little bit longer even than that, they'd probably tell me what they wanted me to do about it. So fully NHS practice, no private GP patients. 5 of us, the plus one, there were 5 clinical partners, the plus one is an administrative partner. Again, this is part of the more business-like approach of general practice, and in my practice we now have one partner who's the senior manager and administrator. So 5 clinical partners looking after 8,300 patients. Family practice, question mark. Of course we have family doctors, but I think certainly by the time I came to leave and through most of it, I felt that I'd been part of an extended family working there, and that's something I'll come back to. Tuesday meeting is just shorthand. I think we were very lucky. And I don't know how many practices that you all work in this would apply to, but we did have a regular weekly meeting. Nurses, not receptionists, but nurses, all the clinical staff would sit round, have a sandwich, talk quickly about referrals to each other, but most importantly, every fortnight, spend longer talking about maybe 2 families over a period of about an hour. So there was an opportunity for a little bit of discussion in more than usual depth. On a regular basis, and personally I think that's very important. It's pretty rare in the UK, and my guess is, I hope I'm not misjudging you, it'll be fairly rare in Sweden as well. I hope it isn't, but it certainly is in the UK, pretty rare. but I think very important for that basic sort of professional bonding to a practice, if you've got the space to talk about the things that trouble you, really. That's just outside the practice, giving you a picture very different from the forests of northern Sweden, just outside my practice, so very multi-ethnic. Amazing proximity of different communities. I could open my door in the practice and find somebody who's very prosperous, maybe to be contemporary we refer to them as a banker perhaps, or the leader of the House of Lords or somebody, right next door to a recent arrival from a Bengali, Bangladeshi village. So unbelievably mixed population, but essentially pretty socio-economically deprived, one of the poorest areas of inner London. Won't go over this too much, but that gives you an indication of our consulting difficulties simply in terms of language. Sorry. 40% of our patients had English as a first language. So 60% have reasonable language fluency, 40% not at all. Going right down to 5%, which would be 1 in 20. So one patient, a surgery would often be 20 patients, so one patient in an average surgery would have no English and no interpreter. Can't remember what's next. Oh, that just gives you, I'm sure that would be very much the same as in Sweden. That's a mixture of the people that worked in the practice. Now, no? I don't know what the murmuring is about. Maybe I'll hear later. They're not all employed by us.
A phlebotomist, what is that?
Taking blood.
Phlebotomist.
Who got it right? Any other translation difficulties? Okay. Now, for me the thing that really made sense of being a GP was the work of Michael Barlin. And I'm a bit of a Barlin freak. I ought to sort of, hold up a sort of warning for you all, really. I went into a Barlin group very early on in my time as a GP in the early 1970s, and it remained really the theme of my professional life, really. Because if you are lucky enough to have continuity, or sufficient continuity, it doesn't take long before you realise that the purely medical aspect of being a GP is only half of the story. Why do people keep coming back to see me? What is it that they really want? Why is it that sometimes I really wish they would go away? Sometimes they seem to have the same problems as I do, and therefore I want to see them more often, all that stuff. So I went into a Barlin group, and it was the sort of core role anchor for me. Now, I know there are many, many other ways of approaching general practice, but that was the one that really made it for me. What did I learn? I certainly learnt number 4 or 5, that life is not a treatable condition. And I learnt that, I suppose, from listening to the stories of my fellow GPs in that group, from whom I learnt a huge amount, I think, just listening to experienced doctors talking about their work. After being in a group for a while, of course, I noticed that there were certain patterns in the other GPs and the sorts of patients that they tended to bring to the group. I thought that was very interesting. And then I thought, oh my God, if it's true of them, it may be true of me. So it made me think, oh, what are the patients that I somehow always need to take to a Barlin group? And that journey, for me, was the beginning of trying to understand this, I think, still very undervalued concept of Michael Barnes, the drug doctor. It's one of the things that he's most well known for saying. And it's usually misquoted by GPs. GPs usually, if they refer to it, say that he meant that it was the most powerful drug used in general practice. He never said any such thing. That's GPs sort of, making themselves a little bit more. What he actually said was something more interesting. He said that it was the most frequently prescribed drug in general practice, and that it was part of our responsibility to learn a little bit more about its pharmacology. Now, I think he was way ahead of his time. Maybe the time is coming. It's always remained a kind of important side question, that, but we've only just begun on that journey of really taking responsibility for trying to understand our personal pharmacology in relation to the work we do all the time. Mutual investment company, I don't really need to mention. It was his idea that as patients and doctors got to know each other, capital was accumulated in the account on both sides. The patient got to know the doctor got to know the patient, and then through ordinary daily transactions, and that when there was a crisis of some sort, things could be drawn on from that account. I'll tell you later why I've got it there, but we don't need to dwell. Right, attachment theory. So, as I said at the beginning, here is a huge evidence-based, very key phrase to use in a lecture these days, evidence-based theory. It's basically a developmental theory, which tells us about the early patterns of security seeking, really, early on in life. And the important thing is that those patterns then continue throughout the rest of life. Now, the basic primary caregiver, often the mother, but not always, for infants, is referred to in this theory by a slightly misleading term, the secure base. And in the work that followed early on with this, which was done by Mary Ainsworth, and many of you will know of this, they applied a thing called the strange separation test. It doesn't matter actually, I don't know why I've gone down that route. But it was a way of defining how infants are attached to their mothers usually. And 60% of us are fortunate enough to have secure attachment. 40% are insecure, and are either insecure by being avoidant, so we tend to retreat from emotional proximity when things are really worrying us, being rather English, saying, oh no, it's perfectly all right, no, don't worry at all. Classic sort of national characteristic, which is essentially avoidance. Ambivalent, meaning, I'm sure, we don't really test our care, we don't really trust our caregivers, we like to get close to them, but we don't quite believe what they say, and we're often quite clingy. And then there's a very important group for us, who are the most disturbed of all, but in the population only account for 1% of people who are called disorganized or chaotic, who have very, very problematic relationships with any caregiver. And the important thing about all this is that this is going on all the time while we're consulting. At least I think it is. Well, I'm sure it is. So, when you listen to the modern rhetoric of health, which is very often about shared decision-making, it's very often about a democracy of shared decisions and things in clinical management, all absolutely important things. It's probably only those that are securely attached who can reasonably take part in such a relationship, because they have sufficient trust of their doctors to be able to do so. So they can consult with a reasonably good idea of what it's reasonable to sort of expect a doctor to be able to deliver, and participate and take what they need and go their own way. But for those that are more, have more insecure patterns, things are much more complicated. Now let me just give you one or two illustrations of this. I think some of these patterns are very relevant when we come to organising preventive care of long-term illnesses, for instance, because we tend to do that by issuing invitations to people to come in for checkups and stuff. But what we don't realise is that some people, that's quite problematic. So a research question would be, can you make asthmatic patients worse by actually following them very assiduously if they've got avoidant structures to their personalities? It may seem a very futuristic question, but there is some of this just beginning to trickle into the literature. There's a very interesting study just been published in America which shows that diabetic patients who have insecure patterns of attachment have a far higher mortality at 5 years. Interesting. And if you begin to think about it, it's not that surprising really, because if you distrust caregivers, you're not going to have a straightforward relationship with them, and you probably don't get quite the same care as if you've got a secure relationship with your GP. So, the other thing, just to mention in passing, I think, is that although I mentioned the disorganised and chaotic group, sounds like a description of most of us, doesn't it, really? But have 1% of the population, but they're probably in excess of 10% of the consulting population. Because I don't know the figures, what is it? About 10% of our lists consult us 90% of the time, whatever it is, 30, 70, something like that. So they're and they often contain children of who've grown up in abusive families with multiple separations and all sorts of things. A very important group. So, now, that's just a quick thing to bring us down to earth a bit more, really, about possible groups of patients who might have a special need to feel securely attached to their practices and are not necessarily always coming for medical interventions, but it's important for them to feel that there is a home, a place, a secure base, somewhere where they feel recognised, where they feel that their histories are known about, where the doctor somehow contains some knowledge of them. And I just put refugees, quite obviously the case. Those that are marginalised in society, very often a practice can become a very important sort of base of security, provided the practice can tolerate them. Mothers, parents of small children, the elderly, bereaved, and, this is the point I really want to make, right. There's a sort of prevailing assumption, I don't know how many of you feel, that actually your sort of units of medical provision these days, that you just have to provide services. And there's a basic law which really comes from attachment theory, which is that people can only look after other people if they feel reasonably well looked after themselves. Absolutely fundamental to attachment theory and the interaction between mothers and infants. And it seems to me that in the drive to put patients first, which is a slogan that is used a lot in the UK, and of course it's right, but what it leaves out is that patients only get a really good deal if the doctors are in reasonably good shape. There's no point in going to see somebody who's sort of just about to collapse. You know, it's amazing that it's been missing. Anyway, so the attachment theory and the notion of a secure base invites us to think about what sort of state we're in. Now, is this a useful concept for general practice? Is it worthwhile as a discipline beginning to think not so much of ourselves as individual doctors, but in thinking about the organisation and the practice where you work, the health centre where you work, and whether it's difficult to describe, whether it itself thinks about itself as a therapeutic organisation, and therefore the welfare, feeling of attachment, and sort of sense of security that the professionals have is actually a key component of what the practice offers. And obviously there are a lot of questions which follow that as to what actually makes a practice feel like a secure base to professionals. I think, and I've mentioned a little bit about understanding patterns of consultation. I always remember a woman who, whenever she consulted me, the very first thing she did was to pick up her chair and move it further away. Fairly sort of strongly avoidant pattern. And in the same way, I can remember a man who, whenever he was trying to describe how he was feeling, would always demonstrate where his area of pain or discomfort was on my body. He always popped round the desk and said, "Just there! There!" You know. And in case I was in any doubt about how painful it was. So, in short, I think there is quite an interesting journey for us to have in beginning to apply some of these things which I can only just begin to sketch a bit, which derive from attachment theory, but looking at some of the work and some of the things that are important to us as GPs, really. Now, of course, it's not only patients who become attached to their practice. I haven't really said enough about it, and I don't think I've explained quite what I would like to explain about that, which is that there is something about, you know, patients who come to you and they say, I just feel better for having seen you. And you wonder what it is you did. Well, attachment theory tells you you're a sort of figure, you're a secure base in the patient's mind, and proximity, just being with you, it's peculiar to sort of to accept, actually makes people feel better. Why are appointments curative? Anybody ever bothered to think about that? I mean, often people that don't arrive for appointments feel better because they've made an appointment. The anxiety is felt in relation to whether you can get through, whether you can remember the phone number, whether there's going to be an appointment, whether the receptionist will put you off when you get through. All that, the anxiety is up and up and up. As soon as you've got your appointment for the person that you want to see, somehow anxiety levels come down and you feel quite a bit better. So there are all these quite interesting, maybe minor, but sort of noticeable phenomena about behaviour between patients and doctors, which are all, I think, can be understood more fully by this. And I think certainly patients' stories, the stories of their families, stories of their illnesses, tend to come to sort of reside almost in a practice. Once there's been a sort of pattern that's developed and generations have come to the same place, it's not, the content of that isn't just in every single interaction. There's something, it becomes a sort of library, a kind of communal history, a place where the, you know, stories sort of reside, I think, a bit. And that all can be understood in terms of the secure base. Now, Marcus in his introduction did mention that you've been very generous in putting up with a retired GP. I've actually finished for 4 years. And I want to finish my talk by just thinking a little bit about the whole question of leaving practices. Because, of course, you know, if things go well, professionals themselves get pretty attached to their practices. And as I approached my retirement, I looked around for guidance about how the hell to go about this. Nothing there. And I should just say, it's not only retirement, of course. People are leaving practices all the time. Maternity leave, changes of jobs, deciding to go somewhere else. what happens to the separation, the parting of patients and doctors? Do we give any attention to it at all? Both from the patient's point of view, but also from our own point of view. And I'm only suggesting that something should just be put out there, so that if anybody does want to come and say, look, you've been pretty wrong, and I'm very glad you're going, they can at least do it. I don't mean that everybody's got to come in and sort of say, goodbye, best of luck. Not at all. But what you actually hear when you chat about this subject is people almost always say, oh, absolutely. My doctor left last week, or my milkman doesn't come anymore, or the newsagent doesn't deliver papers anymore. People are much, much more dependent on the stability of these things than we realise. And obviously, a doctor leaving, if somebody has been a patient for, well, even if they've been a patient for a year, certainly 5, 10, is quite a significant event. So I looked around, the literature, absolutely nothing, more or less nothing at all. It's as though nothing's mentioned. Anecdotes abound. People become ill. People say, oh, well, the chap in my practice, he just didn't turn up on the last day. All sorts of stories about how difficult it is for us, GPs, to separate, to leave, to do it in a way which is communicative and open. I got good advice from one or two of my colleagues. One said, make sure that you do it your way. In other words, don't allow your last week after 36 years or something to just be decided about by the sort of practice organisation. In other words, you might be the emergency doctor on your last surgery. So that was good advice. And I decided to give plenty of notice. I gave a year, actually, for my patients. And I asked for the last month or so just to be left free so that anybody who wanted to see me could come and see me. And just as much for my sake as theirs, I'm sure. This was a big separation for me. It was very, very interesting to see the sort of patterns that then emerged. And some of them, I think, are probably relevant to the patterns of attachment that I was talking about earlier. There were, of course, plenty of people who didn't want to come anywhere near, didn't want to say anything, and they were, avoiding the whole question. In fact, one of the reasons why I decided to give plenty of notice was that I was very struck by a patient who I saw one evening, this was before I had decided to retire myself, who told me that she hadn't even been able to come to our building since one of my partners retired for 6 months after he left. Couldn't even walk down that bit of the street. And I thought, God, there's really something happening here. And I don't think, one of the important things about that, I don't think he would have known. I don't think that doctor would have known that he mattered as much as he clearly did to this woman. So that was one of the reasons I thought I ought to give plenty of notice. How to go about it, I'm talking about that. Facing ending is pretty difficult, because if people are upset that you're going, and as I say, it's not to do with retirement, you might only have been there for 2 years, there will be 1 or 2 patients that you've got very involved with. How do you bring it to an end? But if you are doing that, you are, of course, trying to deal with your own sort of separation and mourning at the same time as helping patients with their reactions. So it's not surprising we avoid it. It's quite a tough one. Some people, of course, are very healthy. They come in and they say to you, well, you've been part of our family for 35 years. What on earth makes you think you've got the right to just get up? There's nothing much you can say, really, but pretty straightforward communication. There was one man, I suppose this would be clinging, a sort of ambivalent clinging. One man who actually was a surgeon, who I hadn't known for very long, but he was so incensed that I was leaving, he wanted to set up in private practice a special partnership of just him and me. After leaving, and he was really determined. He had a little business plan, he brought in all sorts of things. So that was certainly clean. It's really very striking. But again, I suppose those who can deal with it were able to fairly healthily ask, oh, well, I'm very sorry, hope all goes well. Sorry, who's looking after me next? You know, good, healthy self-interest, really. And some were able, these perhaps from my point of view were the most satisfactory, we were able to have maybe just one or two consultations where we were able to kind of reflect together on the events that had happened over however many years it might have been. And I was amazed that two people could remember their first consultations, sometimes 20 years before, and told me about them. But it was just a couple. But to have that sort of sitting back and sort of just thinking together about what had happened, you remember old Aunt Molly and all that sort of thing, was a very precious experience. And one thing that was totally unexpected for me was that having left the last month of appointments open, the pattern that some people went into in that, I had not expected some people to come more and more and more often. I suppose it's obvious, really. You know, if somebody's going, and maybe there's some sort of connection with them, you want to see them. So I was amazed by a small number of people, right at the end, one who came daily, and one old lady came twice on one day. At the end, so extraordinary stuff. And I suppose, you know, I'm describing it in a way which is perhaps light-hearted, but there's a serious subject here, I think, about how we do take our leave from such significant work, significant at a human level as well as at a medical level. And for me, it's really the reason that there is so little attention that's given to it is because of our massive denial of the human relationship side of medical practice. If it wasn't so strong as it is, and it's strong for good reasons, I wouldn't entirely knock it. Then, of course, there would be more attention paid to these things. But because we all subscribe, in a way, to the idea that medicine can be done efficiently and effectively and, you know, everything else-y, but without much of a sort of human contact, and you can move doctors from here to there, and that's really... We all do subscribe to this in some funny way. And if we do, of course, all these sorts of things get completely left out. Now, because Marcus is such a lousy chairman, we started late, didn't we? No. So I am actually just finishing. I just want to mention putting Barlind and Bowlby together. This is a real interest of mine, and I won't say much about it. But Barlind groups, I don't know about Sweden. You have the president of the International Barlind Federation, of course, in Sweden, Henry Jablonski, a psychiatrist in Stockholm. You have a very distinguished researcher, daughter Kjellman, who's a GP in northern Sweden. And so maybe Barlind work is flourishing in Sweden. But I think the old days of GPs going into Barlind groups, talking about their cases on a weekly or regular basis, it's very, very difficult for people. There are so many time pressures. It doesn't seem to be a mainstream activity anymore, certainly not in the UK. But what is perhaps beginning to happen is what I was referring to in the Tuesday meeting of my practice. A recognition in organisations that professionals do need to talk about their work with each other. And so Barlind groups are beginning to be practice case discussion groups, more and more. And as, certainly in our system, we're getting more and more salaried doctors, maybe there is a help in feeling attached to the organisation where you work, if it's one that does provide some sort of framework, some sort of space for people to be able to talk about their work together. So that's a sort of, and there's a very interesting, there's an Israeli group who've just published something about the effectiveness of a Barlind group in which a GP brought a case which she was having difficulty with, And then it transpired that the GP was about to leave the practice. And once that became clear, much else became clear about the difficulties that the doctor was having with that particular patient. So these things do all link up, is really all that I want to say. And as I mentioned earlier, there is evidence of improved outcome. So this isn't just only to do with the qualities of relationship, the doctor-patient relationship, but there may well be some serious evidence, medical outcomes that are related to it as well. So I'll leave you there. I had to think what to give my practice when I did finally prize myself away. And I thought to myself, well, what best sums up the 35, 36 years that I've been sitting in that room and people have been making appointments. And luckily I found this, as I hung up my stethoscope, I found a little cartoon by the British cartoonist Christopher Hellman, which completely summed up what I thought I'd been doing. Thanks very much.